كلنا عارفين دكتور محمد أمارة. Years we are working together, and he will present now his talk. اتفضل دكتور محمد.
Thank you, Dr. Maha, for the introduction. I'm Mohamed Emara, Regional Manager for Centogene. Through our presentation, we will be talking about the different technologies used in molecular labs. When the physician could order for his patient a specific test and what to order in specific. Moreover, we will talk about an overview about Centogene services and what can Centogene provide for the physicians to help in their patient diagnosis. First of all, we will talk about the lab technologies. As we can see, many physicians in their clinical practice either can suspect a clinical disorder depending on a chromosomal abnormality, or can suspect a clinical disorder depending on a genetic abnormality. So for the first part, we will talk about the chromosomal disorder. Either the chromosomal disorder is a numerical disorder or a structural disorder. The numerical disorder, as we all know, that the chromosome is in normal state is disomy. The numerical disorder goes for monosomy or trisomy. The structural disorders go, as we can see in the picture, specific deletion in the chromosome, or inversion in a part of the chromosome, or a deletion or duplication for the chromosome, or a translocation where the part of a chromosome is translocated into another part of the same chromosome or another chromosome. Okay, when we consider the analysis for chromosomal abnormalities, if the patient is facing an unexplained developmental delay, or the patient have an intellectual disability, or there is a suspicion for autism spectrum disorder, or the patient have multiple congenital anomalies. So in these conditions, we can suspect a clinical disorder related to chromosomal abnormality, and the physician could search for a technique that covers this chromosomal abnormality. For the techniques, we have almost three types to detect the chromosomal abnormalities. The first is the karyotyping, moving on to fish analysis, moving on to microarray. Every technique have some advantages and disadvantages. As you can see in the advantages of the karyotyping, it can detect the large chromosomal abnormalities. It is of low cost and can detect the balanced chromosomal translocations. While the disadvantages of the karyotyping, it cannot detect the complex chromosomal alterations, also cannot detect the tiny small deletions and duplications related to the chromosomes. Also, it cannot detect the methylation. For the fish analysis, is more specific and sensitive than the karyotype, where we prepare a certain probe to detect a certain abnormality. So it can detect a chromosomal abnormality, either numerical or structure. Also can detect the complex chromosomal rearrangement that cannot be detected by the karyotype, but its limitation that it's more expensive than the karyotype. It is limited to the common abnormalities because the probe that we are using is limited to a certain abnormality that we are searching for. After that, they developed the microarray. The microarray have an advantage that it can detect the small deletion and small duplications that cannot be detected by the karyotyping. It also can detect the unbalanced chromosomal abnormality, but one of the drawbacks that it cannot detect the balanced chromosomal abnormalities, plus that the price of microarray is still expensive than the normal karyotype. So if I'm a physician having a patient and this patient is suspected to have a chromosomal abnormality, the first option that I can detect or I can think about is searching for a techniques, either the karyotype or the microarray, to detect this abnormality. Second, we will go, if it is not a chromosomal abnormality, so we are searching for a genetic abnormality. The molecular labs have different technologies used to detect the genetic abnormality, either by sequencing, deletion, duplication analysis, or repeat expansion. The sequencing, as we can see in the pictures, that the sequencing can detect either abnormality in the sequence of the gene itself, or can detect small indels and small insertions or deletions in the sequence of the gene. But it cannot detect the large exonic mutations, which can be detected by the CNVs or by the MELPA technique. We can see here that the MELPA technique, this is a case of DMD. This is the normal graph for the normal DNA, and this is the proband graph for the affected DNA. We can see that there is some deletions in some exons of the DMD, and here comes the role of the MELPA to detect the deletion duplications on the exonic mutations. Moreover, the repeat analysis. The repeat analysis is a technique used when there is base pairs repeated more than 50 times. There is a defect in the sequencing to detect these base pairs, because when the base pairs are repeated more than 50 times, the machine could give an error. That's why the repeat analysis technique is used. As a clinical application for those three different techniques, we can see that if a physician now is sitting in his clinic facing a patient, and this patient has a specific disorder related to specific gene, we can know by the guidelines the common mutations in this gene, if it is a single point mutation or a small indel, small deletion duplication, we can go for a single gene either by Sanger sequencing or NGS. For example, if we have a patient for neurofibromatosis related for an F1 gene, so we can go for the gene directly by sequencing. If we have a patient suffering FMF, we can go directly for MEFV gene. If the common mutation for this disorder is a deletion duplication, exonic deletion duplication, we have to go for MELPA or copy number variants. As an example, for the disorders that can be detected by MELPA, we can see that the DMD can be detected first by MELPA, as about 95% of the mutations or the patients affected by the DMD can be detected by MELPA of DMD. Also, we have the SMA, spinal muscular atrophy. We can detect the SMN1 and SMN2 by MELPA in order to know the deletion and the deletion in exon 7 and exon 8. For the Charcot-Marie-Tooth type 1, we can go for the PMP22 deletion duplication by MELPA for gene PMP22 in order to detect the Charcot-Marie-Tooth type 1. Also, the MELPA technique can detect the uniparental disomy, UPDs, example the Prader-Willi syndrome and the Angelman. Examples for the repeat analysis that we were talking about, the Fragile X syndrome, which is related for the MFR1 gene, Huntington disease, which is related for the HTT gene, myotonic dystrophies like the DMPK and CMBP for myotonia dystrophica type 1 and type 2, different types of ataxias, as we know that there are about 15 genes in ataxia related for repeat expansion. So repeat expansion technique in ataxia is a very essential technique to be considered. As we can see that the FXN gene related for the frataxin gene and for Friedreich ataxia, it is already covered by repeat expansion technique. So all of those techniques are the techniques used in the molecular lab in order to detect a single mutation. We in Centogene have all this in one solution. By the Cento card that you send to Centogene, you can go through a single gene mutation. Moreover, if the single gene mutation is not or inconclusive, the results is inconclusive, we can go for an NGS panel. If the results still inconclusive, we can go for the whole exome or whole genome. So Centogene, we have in one hub many genetic solutions for your patient. We developed our panels in Centogene to be deployed by organs or by disorders. So all the vision disorders are considered to be in one panel. All the movement disorders are considered to be in one panel. The epilepsy is considered to be in an epilepsy panel. Moreover, the kidney disorders is considered to be in the nephrotic panel. We cover all panels by NGS and copy number variants, which give the physician a clinical utility more than the NGS alone. Moreover, we have a uniform platform coverage for all genes in the panel. We also included in the genes related for each panel what genes that could be covered by repeat expansion technique or by MILPA technique to be considered as an add-ons for the panels. So as if the physician nowadays is suspecting a specific disorder, he can cover the disorder by the panel with confident that all genes that related for this disorder is present in the panel, and the different techniques that can be used in this disorder is also covered in the panel. This is for the NGS panels. If the panel is conclusive for the patient and he needs for the physician and he needs to go to whole exome, when to recommend whole exome for a patient, we can recommend a whole exome for the patient if we have a clinical or genetic heterogeneity. Example for the epilepsy and epileptic encephalopathies, the muscular dystrophies and muscle disorders, the different types of ataxia, neuropathies, cardiomyopathies, immunodeficiencies. There is a very heterogeneity, wide heterogeneity for the genetic and the clinical presentation of the patient. And here we can recommend whole exome sequencing. If the patient is coming with a typical clinical presentation or phenotypes, like the PKD1 gene, which is responsible for the polycystic kidney and can cause intracranial aneurysm. If the patient is coming with intracranial aneurysm, it could be not a typical finding for a specific disease. It could be an atypical presentation for a polycystic kidney. If the patient is coming with blended or many phenotypes that not related for a specific disorder, like patient coming with an intellectual disability and severe immunodeficiency, and here we cannot recommend a specific panel for this patient, so we can go for an whole exome. Or even we did before a genetic testing, and the genetic testing came out negative, and we need to go for a broader test. In these cases, we can recommend the whole exome to be considered as an option for a genetic diagnosis for the patient. Okay, on which basis should I select the whole exome? There are three main bases to select a whole exome. Selecting a whole exome based on the technology used. As we know that whole exome, from the name whole exome sequencing, is covering the exonic regions by sequencing technique, which is the NGS. So adding another techniques for the whole exome make better clinical utility for the physician and make better susceptibility to detect the variants that can cause the disease, like the copy number variants, which is related to the exonic deletion and duplications. Also the mitochondrial genes, so as to be 100% sure that we are covering any mitochondrial disorder either related to the mitochondrial gene itself or the nuclear DNA. We at Centogene, from instantly when any physician send a patient for whole exome sequencing, this patient already do the whole exome covering the NGS, the copy number variants, and the mitochondrial DNA. In addition to the multi-omics technique that we will talk about later. Second, the kits used and the coverage of the kits. This is an important issue for the physician to be sure that to great extent the genes covered uniformly with a depth of coverage or mean depth of coverage which is proper to the patient to detect the mutation. At Centogene, we use Illumina kits designed to cover about 99.04% at a mean depth coverage more than 20x. Finally, and it's the main cornerstone in the genetic diagnosis, it's the database and the bioinformatic team which evaluating or making the interpretation of the case. Selecting the database is crucial. We at Centogene have #1 worldwide database for rare disorders. We have been in the field for about 15 years. Every single mutation that we have is confirmed by Sanger sequencing when it is a weak mutation, or the copy number variants could be confirmed by MILPA technique for the like DMD detection, or even the copy number variants when detect a large chromosomal or large exonic deletion related to a chromosome with many genes. It is confirmed also by microarray. Moreover, the clinical team already boosted about 8,000 clinical gene to be covered by 100%. This 8,000 clinical genes is read by the bioinformatic team more than 4 times in order to exclude or include any variant in those 8,000 genes to be 100% sure about the report when it is interpreted. Moving on from the whole exome, the whole genome is used when we are searching for an exonic mutation not covered by the whole exome, or we are searching for a large exonic deletion, the copy number variants of the whole exome cannot cover and it's covered by the whole genome. If we are searching for an intronic mutation or deep intronic mutation that is not detected by whole exome, searching for a disorder with repeat expansion, and here the repeat expansion, we will know that we developed the technology of our new whole genome in order to include repeat expansion, not only the sequencing of genes, or having a negative exome, and we need to go for whole genome, which has a utility to about to reach about 30%. So if we have like 3 cases out of whole exome is negative, those 3 cases we can have a 1 positive case if they go for whole genome. As I told you, the new whole genome now, it is not only covering the NGS and copy number variants for the exonic and intronic regions of the more than 20,000 genes. It also includes the mitochondrial genome. What's new? It includes the repeat expansion for 23 genes. As you can see, you can find the FMR1 gene in the whole genome, so it can detect Fragile X. The Huntington HTT gene can be detected in the new whole genome. The genes for ataxia, the different types of genes of ataxia, covered also by repeat expansion, so it could be covered in the new whole genome. The DMPK and the CMBP related for myotonic dystrophy, which was mentioned earlier, also included in the new whole genome. So the new whole genome not only covered the NGS and copy number variants for 20,000 gene, but also covered the repeat expansion. It also covers the spinal muscular atrophy C and V analysis, which is could be some sort of a preliminary diagnosis for the SMA exon deletion in deletions in exons 7 and 8, upon which a confirmatory test is done by MILPA to ensure that this patient is SMA or not. Also, the GBA1 inversion, the gene is a predisposing gene for Parkinsonism and for Gaucher. It's also included in the new whole genome. So our new whole genome can include all this new technologies, which cannot be covered first by the NGS alone. Also, the new whole genome is susceptible for the new multi-omic approach. Our new multi-omic approach now includes the biochemical and biomarker. To be more simple in this point, when a patient is diagnosed with a variant, and this variant is related to a certain disorder which have a biomarker or biochemical enzyme, this biomarker or biochemical enzyme is done as a refractory complementary reflex analysis on the backbone of the test in order to confirm the diagnosis. So if we are going to have a metabolic disorder diagnosed by whole genome or whole exome, and this metabolic disorder is related to a certain enzyme or certain biomarker, this certain enzyme or certain biomarker will be done for free. Moreover, nowadays we are developing a new technology that will be a very, very good revolution in the whole exome and whole genome, which is the messenger RNA. As all you know, that messenger RNA, which is responsible for protein synthesis, It could be like a signal if the variant identified in the whole exome or whole genome is compatible with the disorder or not through the protein synthesis. We already validated our Cinto cards to be available to extract from it the messenger RNA. And now we are in the final approvals for the validation on the technology itself in order to be included furtherly for the whole exome and whole genome. So this new multi-omic technique, it can reduce the variant of uncertain significance that could face many physicians in their daily reports of the whole exome, either to be confirming the diagnosis and be likely pathogenic or pathogenic, or could go to be a benign or likely benign variant. This was requested mainly from Dr. Hoda. She told me to talk about the variants or the classification of variants. Our classification is done on the ACMG guidelines. The classification either go for pathogenic or likely pathogenic, and the pathogenic is a disease causative variant, which is found in the guidelines with a good number and good clinical relevance. The likely benign and the benign are not causing disease. And this also have a good evidence by number of patients and by clinical relevance. The gray zone in the middle, which is the variant of uncertain significance, it remain not meeting the criteria either to be pathogenic or likely benign. It have some overlapping clinical evidence, but not in a good evidence or a good number of patients to confirm that is pathogenic or likely benign. So that's why it's kept in the orange or the gray zone. In this situation, we do recommend first to segregate the parents in order to know whether there is inheritance for this variant from the patients, from the parents or not. Second is to clinically re-evaluate the patient. Upon the clinical re-evaluation, we can see the interpretation of the variant, if it is overlapping with the phenotypes or not. And on that base, we can see if Centogene on its regular reclassification program will shift the gene to be likely pathogenic or to be likely benign, and this will be notified for the physician on also free of basis charge. He will get a notification that the variant that was identified before in your patient was reclassified to be either likely pathogenic or to be likely benign. Here we can see like sample reports. This is a sample report for the whole exome. In the first, you can find the clinical information provided by the physician, and this clinical information is crucial. Dr. Noha, I think, was talking about the artificial intelligence and how it is used now in treating patients. As you can see, the machine is not the only factor. The human or the physician, the picture he see for his patient is crucial, that the bioinformatic using the machine can detect what the physician can see. So writing the clinical information is very, very important. Providing the more clinical information for the patient, and every single phenotype can count on. For this report, we can see that this is a positive report where a copy number variant identified in a mitochondrial gene. And here comes the clinical utility that I was talking about. In selecting the whole exome, try to select a proper technology that can cover the copy number variants and the mitochondrial genes in order to have a diagnosis. This clinical utility increased by increasing the technology and using a proper database. So keep it in mind to select a proper technology with a proper database. This is another sample report for a patient diagnosed with limb-girdle muscle dystrophy. And this is a sample report for a whole genome case. Also, as you can see, every report, we here write the clinical information. Either the results is positive or negative, then the interpretation of the result showing the zygosity, the state is whether it is homozygous or heterozygous in parallel with the disease. Then we interpret the gene itself, and we state what this variant could cause for patient phenotypes. Other point, mainly recently in some Centogene reports, you can find that the report come negative, but in the first table here, sorry, in the first table here, you find under the negative report that a potential relevant identified. We already in Centogene, the bioinformatic team, when they do their analysis and filtration, if there is a potential relevant that have some overlapping phenotypes with the patient, this overlapping phenotypes is written in a potential relevant finding, because the physician have to look for this variant, look for the disease causative by this variant, and then re-evaluate the patient. If this patient is already having a phenotypes that suspected to be the same disorder as mentioned in the potential relevant variant, this potential relevant variant could be a diagnosis for the patient, upon which a clinical report or an email could be sent for the clinical bioinformatic team in Centogene, and upon which the report could be changed from negative to positive. Mainly that's all for my presentation. Welcome for any questions.
Thank you very much, Dr. Mohamed, for this
Thank you, Dr.
comprehensive presentation about how which test should be chosen and about the variant. Anyone have any questions?
So we have these problems when we ask for gene tests. We have to know what do we suspect, so as to ask for the proper test. Yes. So and many times when I suspect Charcot-Marie tooth, and after I ask for whole exome sequence, then I start again and ask, please, Mohamed, do for me the PMP by deletion by MELPA, because I missed, it can be missed in the whole exome. So my question is it included in the panel that you have deletion duplication for something that like the PMP22 gene?
Already in our panels, as I told you, Dr. Huda, we have implanted some genes with different technologies, but I have to go back to the panel in order to revise if the PMP in specific, PMP22 by deletion duplication is included by MELPA in the neuromuscular panel or the polyneuropathy panel or not, in order to answer the question.
So what we are missing when we ask for whole exome is the tandem repeat number one. Anything with tandem repeat, we are missing it.
Yeah. For the MELPA, for somehow there is tendency for the copy number variants to identify the deletion duplication. We do have some reports that suspected to be Duchenne muscle dystrophy. The copy number variants identified that there is a deletion in some exons for the DMD, and it was confirmed by MELPA, and then the report came out that this is a DMD case.
You can miss a deletion duplication,
but we can miss
if you ask for whole exome or gene mutation.
From cost point of view,